Oh, thank you very much.
Mhm.
Here it is. Throw it right there. Thank you.
You can start whenever you're ready.
Oh, great. Thank you. So welcome everyone to the COVID-19 vaccine question and answer session with Southern Ontario Collegiate and Hamilton Public Health Services. The goal today is just to provide some evidence-based information, and there will be time at the end for anyone to ask questions for Dr. Ayani. So we're going to go through some pre-submitted questions first, and then we'll open it up to the audience for anyone else who wants to ask any questions. Okay, so I'm just going to let everyone introduce themselves first. My screen is frozen. One moment. Sorry about that.
Should I go ahead?
Oh, I keep freezing. Let me try again. All right, there we go. Dr. Ayani, do you want to start?
Sure. My name is Dr. Olawale Ayeni, and I'm a family physician in Hamilton, Ontario. I've been in practice here for over 11 years and in the US for 15 years before that. And I'm very involved in governance and public health and advocacy. And I'm certainly quite passionate about vaccinations as a public health tool for prevention and COVID vaccinations in particular. And I look forward to having a great conversation today and answering some questions and hopefully changing some minds.
Great, thank you. And Katie, did you want to introduce yourself if you're back at your desk?
Hi, I'm Katie. So I'm the head of human resource and accounts for Southern Ontario Collegiate. I work very closely with Sharon and she keeps me up to date on all the updates with public health. So we're very happy to welcome you both here and I look forward to the presentation.
Great, thank you. And thank you for helping to make today possible. And my name is Sharon Munn. I'm a health promotion specialist with Hamilton Public Health Services, working on the vaccine confidence team. And I'm also a high school educator. All right, so these questions were pre-submitted. So I'm going to ask the questions and Dr. Ayani is going to give us some answers. So first question, how do COVID-19 vaccines work?
All righty. So COVID-19 vaccines work by stimulating the immune system to produce antibodies. And that's pretty similar to how many vaccines have worked over the decades. So with vaccine developments all over the world is one of the biggest breakthroughs of the last century. And COVID-19 vaccines are of two different camps. Yeah. And the one we hear more about is the messenger RNA technology, which was actually fine-tuned for COVID vaccines by Pfizer and Moderna. The mRNA technology has been in existence for over 10 years, primarily in cancer research and cancer treatment. And what the vaccines do is that the mRNA will introduce a very harmless spike protein, which mimics the COVID-19 virus itself. And by introducing that spike protein, your body's immune system will recognize that spike protein as a foreign agent and will produce and develop antibodies that will be lurking in the background so that if there is ever any exposure to a true load of the infectious COVID-19 virus itself, your body's immune system and the antibodies are ready to fight off and attack the invading viral particles. So the spike protein is how the messenger RNA technology works. J&J and AstraZeneca are slightly different. They use a more traditional method of stimulating and producing antibodies, but even those also produce killed antibodies. They are not live viruses or live material being introduced into the human body.
Great. So can you just clarify, is there any way you could get COVID from a vaccine?
Thank you, Sharon. And it's very important to emphasize that point. A true virus, the live virus, is not being introduced into your body, into anybody's body. And therefore, you cannot get COVID-19 by being vaccinated. And the other thing is, after an infection, people will develop some immunity, and every virus and every disease is different. So even after COVID-19, you may have read or heard that you could have some immunity for 60 days or 90 days or possibly up to 180 days. But the antibody titer will always decline over time. It will always drop. And we find that the immunity conferred by getting an illness is not the same or as good as immunity conferred by being vaccinated in advance of being exposed to a disease. I'd rather take my chances and get vaccinated than all these theories out there about if you get the disease, then you're immune and that's a better strategy. That's not.
Great, thank you for clarifying that. The next question, are the COVID-19 vaccines safe and are they effective? And I believe these questions kind of stem around the fact that development and approval of the vaccine was fairly fast.
So nothing is released into the population without being properly studied. No vaccines, no medications, different time spans, different time frames. But COVID-19 vaccinations were developed very, very fast. And that's because the mRNA technology in particular, like I said, has been around for over 10 years, used to target cancer cells and used in oncology research for chemotherapy and ways of treating cancer. So it wasn't very difficult for the pharmaceutical companies to actually rejigger the technology to introduce the spike proteins and have the immune system work in building up antibodies and fighting off COVID-19. Normally, there are barriers between companies because they are, again, competitors, because in a capitalist model, you want to get market share, and there's nothing wrong with that. But for COVID-19, that was a worldwide pandemic. The barriers were broken down very quickly, and there was lots of collaboration between governments, industry, pharmaceutical companies, researchers in private environments and public institutions. And once they collaborated to share their data, they could, again, develop these fundamentals and the foundations of the vaccines within about 6 months. The vaccines were also tested in over 70,000 people worldwide, and the 70,000 people involved a mix of racial backgrounds. So whites, Hispanics, Black people, Asians. Again, at least 35% or so were Black and Latino and Asians, and then 65% or thereabouts Caucasians. So it's been tested in all sorts of racial backgrounds and age groups also, and been tested down to 12 years of age right now. And we're waiting for approval for below 12 years of age. The difference this time around was also the fact that normally when there's no worldwide pandemic, research and development goes on over months to maybe a couple of years or thereabouts. And once the vaccine is approved, then the manufacturing starts by the drug companies. And then that may take another 6 months, 1 year before the product is released. But in this case, once we had the fundamentals of the chemical structure of how the vaccines were going to be, the companies actually basically took a gamble, if I may use that word, and started the manufacturing process. If the vaccines were not approved, and there was a real risk or chance that they were not going to be approved, they will have wasted all these vaccines they had produced and they will have lost a ton of money. And that was a worthwhile possible sacrifice for the fact that we had to fight this disease head on. But in this case, the manufacturing process went along and the vaccines were ready. And once all the testing occurred of the 70,000 plus people, and they were given conditional approval, the vaccines could be released right away because they were safe. And that's why it seemed like things went very fast. But again, things went very fast because the technology of 2021 is way different from the technology of 2000. And the analogy I use is like banking. It's like I can take a picture of a check and from the app on my phone, it's deposited into my account right away. And nobody's arguing that in 2000, you had to go to the bank 20 years ago, line up for 30 minutes and give it to a teller. And that's the only way a check could be validated. Now we trust all those technologies and we don't argue that it's for the good and betterment of society. Efficacy, the vaccines range from 65% to 95% efficacy, typically after the second dose. Johnson & Johnson is being shown to be about 65-70% effective, and it's a one-dose vaccination. AstraZeneca is slightly higher in the 80s, and Moderna and Pfizer mRNA vaccinations are effective with about 95% efficacy after the second dose. And typically there's about 4 weeks between dose number 1 and dose number 2. And then 2 weeks after full vaccination is when the maximum efficacy is reached and beyond.
Perfect, thank you. And I just included a slide here from the Ministry of Ontario website showing COVID-19 cases by vaccination status. And this was updated data as of September 12th, so a couple days ago, showing the rate of COVID cases per 100,000 population. And the unvaccinated is in purple, the partially vaccinated in pink, and then the line closer to the bottom of the graph are the fully vaccinated individuals. So you can see that the risk of getting COVID-19 is significantly higher in the unvaccinated population and then the partially vaccinated population in comparison to fully vaccinated. So you'll see that vaccines don't eliminate risk completely, but the number of COVID cases right now, the majority are in unvaccinated individuals.
Thanks, Sharon. Absolutely.
So next question, what are the potential side effects of the COVID-19 vaccines? And then if you could touch upon whether or not vaccines affect fertility as well.
So like many or most medications, there could be side effects. And I use the word could, not will. So being aware that there could be side effects makes you mentally prepared, but not in a way to invoke anxiety or be scared in advance. And in fact, side effects show that the medication is indeed working and it's stimulating the immune system and it's producing the antibodies. So the commonest side effect will be injection site reaction. So when I got my vaccinations, the following day, my arm felt slightly sore. I knew a needle went in there. And that's a human reaction. There's a nerve there that's very angry for a day or two. Tylenol, nothing crazy. I took Tylenol, I was perfectly fine. You could have soreness of other muscles, which are not the muscles of where the injection went in. You could have diffuse body aches and pains, a very low-grade fever. Most of these side effects are usually within the first 24 to 48 hours, and they usually occur after the second vaccination, but they are almost always self-limited. There could be generalized fatigue, just feeling achy and icky and tired, again, for a day or two. It's very rare to have side effects beyond 72 hours. The rarer side effects that have been reported in younger people, adolescents, and folks, males more than females, is pericarditis and myocarditis, which is a slight inflammation of the lining of the heart. And again, thankfully, that's fairly self-limited and responds well to non-steroidal agents. I think there's some background.
Sorry.
Yeah.
Can everyone who's on the call please mute just so we can hear, please, and thank you.
Yeah, so side effect profiles are indeed possible, but usually not of any significant debilitating effects, and they are transient, self-limited, and show that the immune system is working. And to the specific question of vaccines affecting fertility, there's been no studies that were done. We haven't had the time frame in the last 18 months to look at fertility as a specific endpoint. But again, as the data has come out, and anecdotally, there's been no shortage of women who have gotten pregnant after getting their vaccinations. Many of them have brought their babies to term. Babies are now being born 9 months later, and there's been no increased risk of any effect on premature labor or birth defects or babies that have been born with genetic or other abnormalities. So females have nothing to fear. It doesn't affect reproductive ages or menstruation or fertility in itself. And some of the anecdotal reports you may have seen on YouTube of the anti-vaccine people saying they know somebody that got a shot and they couldn't get pregnant for 6 months, or they had a miscarriage 4 weeks later. Again, correlation is not causation. It's again a coincidence of timing, and people have miscarriages or reasons for not being fertile for 1,000 myriad other reasons.
Great, thank you. Yeah, sorry, my screen is freezing today. I'm just gonna restart. All right, so can you already touched upon it a little bit, but how does immunity work? Do you think that there will be a third shot or yearly boosters?
So again, as we said earlier, immunity, the concept is you present an antigen, a spike protein, a fraction of a virus or a killed particle of a virus into the body. We inhale toxic substances all day long in dust, in the atmosphere, in food. So there are many things that enter our bodies, and our immune system is primed and ready to fight off all those infections and bacteria and viruses in the air on a good day anyway. So when you present a spike protein to the immune system and the T cells and the B cells kick into action to produce antibodies, which are now lurking in the background because of that low dose exposure. So when there's a true inoculation or a true inhalation, then your immune system kicks into overdrive. And many times it will be immunoglobulin G, which will last in the system for a prolonged period. Now, COVID is fairly new, COVID-19 specifically, one of the subtypes of a coronavirus. And we're still studying the immunity in research environments to see how long the immune system boosting is lasting. Now we're finding out that it may last for about 12 months in some people, it may last about 18 months, and some people still have high rates of immunity. Because there's a potential for a slight drop, yes, now we're saying that a third shot or maybe a yearly booster may be needed. The third shot, right now, they're studying it and thinking by month 8, after your second vaccine, you may need a third shot. But the priorities are not going to be young, healthy people. The priorities will be ladies and gentlemen in congregate settings, older patients or residents of long-term care facilities who live in a more confined environment, and they are more vulnerable to falling sick from any kind of infection. People with compromised immune systems, they are receiving cancer chemotherapy, they have a genetic reason or an infectious disease why their immune system is more compromised, so they need to be boosted quicker. And then as the data comes out, there'll be recommendations on when the rest of the population might need to get a booster. And again, COVID-19 vaccine may actually become as commonplace as the annual flu shot, which we do recommend anyway in North America, especially, and in most temperate countries, as an annual vaccine that boosts the immune system for when the flu shot prevalence is high, and it takes care of protecting you during the flu shot season. So there may be yearly boosters needed over time as time goes on.
Thanks. That's the fun part about science and learning as we go, right? We'll hopefully, as more and more research is done, we'll know how long this immunity lasts for. So next question, which COVID-19 vaccine is the best for youth? And when will the vaccine be available for those under age 12 or born after 2009?
Great question. And as said earlier, research and studies are always being done very carefully measured with healthy volunteers and even some folks that have pre-existing diseases and conditions. And you aggregate the data and you now generalize to the rest of the population. So the Pfizer and the Moderna vaccines have been studied down to 12 years of age and are approved for youth right now. Below 12 or younger, right now, the vaccines haven't been approved. Now, the good news is I'm pretty confident that the approval will come in very quick time from now. So Moderna or Pfizer, whichever is presented to you, whichever is offered in your setting is the best one for you. Again, hesitancy is part of the problem is when folks do some micro reading and split hairs over the data and say, I prefer Pfizer or I prefer Moderna. I've heard things about this one. My cousin got that and had an illness or vice versa. Both of them are pretty safe at this point for youth. And the timing for under 12 is unknown at this point. But again, they're working very rapidly to get approval for under 12 years of age.
Yeah, great. I've heard that there's announcements coming in early winter. So maybe by the early year, we'll have to wait and see. One thing to note is that in most of the vaccine clinics in Hamilton, you have the option of both vaccines. So part of your informed consent is you selecting or deciding which vaccine you would like to get and understanding the risks and benefits of vaccines. All right, so mixing vaccines was a little bit more common a few months ago and that was mostly due to vaccine supply. And now there's really no need to mix vaccine as we have a steady supply of both Pfizer and Moderna within Hamilton and Ontario. But for people who have mixed vaccines, will that make it harder to travel?
Great question, Sharon. Unfortunately, we've heard stories of folks who have had challenges getting into certain countries. Again, without listing all the countries we've heard, because it's changing by the day. Some countries say, well, we don't recognize the AstraZeneca. If you got AstraZeneca in Canada as your number one and you got Pfizer as number two, well, we don't recognize the number one. So there are challenges in some Caribbean and European countries specifically, from what I've heard. And the government of Canada in particular is working hard to make other countries recognize that AstraZeneca that was given is effective, it's efficacious, and it's safe. And then if you got two AstraZenecas, it's quite safe and your immunity has been built up nicely. If you got AstraZeneca number one and Pfizer number two or Moderna number two, which some data is showing could actually be more efficacious than two Pfizers. Again, they're trying to break those barriers so that various countries will recognize and not discriminate against whichever vaccine was given. Because we indeed pushed the vaccines, we pushed what was available. And again, I believe in vaccines and all the four that are approved right now. And it's a shame that there are some challenges on individual levels of being allowed into certain countries or being recognized. But I hope that will be a historical point within a few more weeks or thereabouts.
Great, thank you. And the next question, why are people still getting COVID-19 even though they're fully vaccinated? And can you still transmit the virus when you are fully vaccinated if you got an infection?
So again, when one listens to anti-vaxxers and some folks who are hesitant and doing research, then there's a skeptical question asked, well, you're vaccinated, so why are people still susceptible to falling sick? And I always say as a family doctor that my job is not to exaggerate points or it's an informed consent. And clearly, if the risks are outweighed by the benefits, it's a go. If the risks are very, very high and the benefits are lower, then it's common sense, maybe not doing that situation or engaging in that risky situation or new offering is probably not worth it. Having said that, we've just discussed a few minutes ago that 95% immunity with the mRNA vaccines. They're fully vaccinated 2 weeks after the second shot, but there could still be breakthrough infections. That's what it's called. It's a breakthrough. Now, the good news about anybody who may get a breakthrough infection is that the risk of getting seriously ill or significant lung disease and hypoxia and needing to be hospitalized or intubated, the risk is very, very low, such that even if a fully vaccinated person has a breakthrough infection, the risk of being hospitalized is so low that it's literally negligible. And I think Sharon may have some statistics of hospitalization rates between those who are fully vaccinated, those who are partially, and those who are not vaccinated at all. So if somebody is exposed in a certain setting, they get ill, they've been fully vaccinated, they still have to isolate, they have to wear masks, they have to wash their hands thoroughly to protect other people around them. Can somebody pass COVID around if fully vaccinated? Yes. If you're fully vaccinated and you get a breakthrough infection, you're still contagious. And in that case, you should still practice what we all did very diligently 12, 18 months ago, wearing a mask, washing hands, keeping safe and isolating from other people, especially the vulnerable elderly and young children.
Okay, thank you. And I do have a couple of graphs. I'm just going to slide this out of the way. Oh, okay, I can't move that right now. So anyway, the top graph is showing individuals in Ontario in the hospital, but not in the intensive care unit. And the darkest color of that graph, the maroony red, are those that are unvaccinated. So you can see that the majority of people that are ending up in the hospital right now with COVID-19 are unvaccinated. And within the hospital in intensive care units, again, the bottom graph, the darker yellowy brownish color are the unvaccinated. So again, a significantly higher number of people within the ICU are unvaccinated individuals. And I'm hoping that this data does become available soon, where it actually breaks it down further by age. And starting on the City of Hamilton website, we'll be able to see local data of cases and hospitalizations, I believe by age, starting this week. So that's something where you'll be able to check and see some local data as well. That's more Hamilton specific, but this is Ontario specific. So the question basically, what are the chances of serious disease for fully vaccinated individuals, and would recovery be faster?
So yes, fully vaccinated folks, because this data doesn't show duration of hospitalization, we can parse the data and break it down into further segments. But it's fascinating that even the data shows that partially vaccinated look like they're spending shorter times in the hospital and ICU compared to fully vaccinated, or lesser numbers of people. But again, we had a patient from the nursing home who refused vaccination. We have 95% rates of vaccination in most of our long-term cares in Hamilton. And this was a sad case because he did not want to be vaccinated for some strange reason. There was a breakthrough infection in the nursing home. He was in the ICU for about 6 weeks and then hospitalized for 4 more weeks. Came out 10 weeks later, hypoxic, some brain damage, now needs a feeding tube, and he's not mobile. He used to be able to walk around before. So if a fully vaccinated person ends up in the hospital, again, we had a situation where there was a breakthrough in somebody who was vaccinated. She had to go to the hospital. She was discharged within 2 days. So her hypoxia and her needs for oxygen were much less, much quicker recovery, no brain damage. So again, I can't speak about the benefits of being vaccinated enough in this conversation. It reduces the risk of hospitalization, ICU care, duration of stay in the hospital, and residual side effects, including what you probably have heard about called long COVID, LONG, where there are all these debilitating side effects and difficulty breathing for weeks and months, even after hospitalization, even after the acute infection and the fevers and the cough have all subsided. Clinically, the people still feel quite crummy on the inside with all these vague, strange, very bad symptoms that reduces their productivity, their ability to go to school or go to work, and it does feel terrible for even up to a year or longer afterwards.
And can you talk a little bit about maybe what has changed with the Delta variant versus the original strain of COVID-19 back from March 2020?
So the Delta variant is a newer variant, newish over several months now. And variants are formed because viruses are very tricky. Viruses are smart, they've been around for millions of years. And when you get a sense that there is more resistance to their reproducing and invading a host, the viruses start to mutate and they develop new spike proteins and new variations of their shell, of the cellular structure, such that the antibodies and the immune system may not recognize it as a foreign agent like it used to do efficiently. So that's how a variant forms. So it becomes more contagious and it's less susceptible to the vaccines that are currently available. And that's a double jeopardy right there, because if it's more contagious, then more people are likely to catch it compared to the previous forms of the virus. And if it's also more tricky and it's more evasive, that's also a bit of a problem. Now, the good news is variants don't form as much if more of the population is vaccinated. So if 80 to 85% of the population is vaccinated, then there's less pool of people for variants to try to use to mutate. And that's one of the reasons also that even if you don't believe in vaccines for yourself or you think you're pretty healthy right now, if you get vaccinated, then your body is not going to allow the COVID-19 virus to form a variant inside of you and therefore spread it to other people. There are strange new variants, again, in Lambda variants in some South American countries, but luckily that's not as widespread or prevalent as the Delta is right now. But to end on a cheerful note or a more positive note, the Pfizer vaccine and indeed the Moderna vaccines have been shown to still be quite efficacious against the Delta variant. So for all we are hearing about the fourth wave in Ontario and in other places, the Delta variant is not resistant. So that's key. It's not resistant to the current vaccines we have. The current vaccines we have are still taking care of the Delta variant, and we hope to get more people vaccinated to reduce the formation of new mutations of variants.
Great, thank you. And I have just one little piece of data. So in Ontario, since December 2020, so since the first people started to get vaccinated, 94.8% of COVID-19 cases were reported in unvaccinated individuals, 4.3% in partially vaccinated, and 0.9% in fully vaccinated. So since the vaccine started, it is truly very high numbers in unvaccinated individuals. All right, so now we're open for questions. If anyone has questions, if you wanted to unmute your mic and ask the question, or you could type it in the chat if you're on your own device. Staff as well, anyone who's on the call is welcome to ask questions.
I think we have a shy group.
Or Katie, if anyone has any questions from staff that you know of, anything else?
No, I think you've covered most of it.
I have a question.
Yes.
Hello?
Yeah, go ahead.
Okay. So I just wanted to find out how long after testing positive would so let's say, for instance, I want to travel and then I do the COVID test and I test positive. So how long thereafter would I test negative? You know, doing nothing. How long does it take to clear the system, to clear the virus from my system, basically? If I'm asymptomatic and I just want to travel and then I tested positive. So that was when I discovered that I'm like, I have whatever. I don't have COVID, so I'm basically an exactly.
Yeah.
So thank you. That's my question.
Thank you.
Well, thank you for that great question. And if I understand it correctly, so there's an interesting thing that happened when COVID was more prevalent and it was spreading like wildfire before we had the vaccines. If you are exposed to somebody with COVID-19, the rule or the instructions were, please stay home for 14 days and monitor your symptoms and keep away from people. You may develop COVID-19, you may start having fevers and chills and cough. So 14 days. But an interesting thing is if somebody developed COVID and was positive, public health will monitor, reach out to you, give you instructions, as well as a family doctor, obviously. And then you were told that 10 days after positivity, if you don't have any fever, you don't have any more symptoms, you're actually cleared, you're free. So I always, even as a physician, I'm like, oh, you have the COVID, but by day 10, well, the worst has happened. You've got the infection and you don't have any more symptoms. Thankfully, 95% of people will do fine. And therefore, day 10 after that. Regarding immunity, again, the data is showing that up to 90 days and up to 180 days afterwards, you could have some antibodies. So I can't speak for every country's rules about letting somebody in, but I know that when a family member of mine traveled to Nigeria and he was trying to come back, his COVID test was positive. So he was told, go away and come back to the airport in 10 days time. He did not have any symptoms or very, very mild symptoms. So he was told he couldn't travel for 10 days. And by day 10 after that, he was considered to be free and clear and he could travel. If a test is done nasally on day 10 or day 11, up to even about 3 months, people are still positive, testing-wise. It doesn't mean the person has the disease at that point. So the nasal swabs can come back positive for several months after a COVID infection. That's also why if you are traveling into Canada right now, everybody has to fill out the Arrive Canada information on the app. And you either can produce a negative PCR test within 72 hours of trying to travel into Canada, or you show evidence of a positive COVID test, I believe is within the previous 90 days. So they will also take that and say, okay, you had a positive test in June. This is now September. So we know your PCR is going to be positive if we do that. So that nasal swab will be confusing to anybody to interpret. So in that case, they will take evidence of a previous infection within the past 90 days that you're good to travel. Of course, they'll still ask you if you have any symptoms right now, and I assume the person won't have any symptoms. So that's a bit of a long-winded answer to, I hope I've answered your question. Miriam?
Yes, thank you, Dr. Ayeni. I have a follow-up question to that. So let's say, for instance, somebody has COVID or they have COVID, and so would they be infective and you mentioned that they will test positive. They could test positive for the next 90 days.
Yes.
So would they still be infective, or are they is it safe to be exposed to such a person?
Great question. So after 10 days of, again, I imagine most people get tested because they either had an exposure to somebody with COVID or they had symptoms, fever, cough, difficulty breathing. So a typical scenario is somebody who knows many people, whether it was a grocery store, a co-worker, a function where people were not masking, they got exposed, a bit of a spreader or super spreader event. And again, with all the news out there, I think most people are aware of their own bodies, and they say, I was at that function on Friday last week. Today is Tuesday. I'm having fever, chills, difficulty breathing. This is day 5, and they get tested. So they get a positive test today. The family doctor, public health agency, nurses, and clinicians will call and check in and kind of inquire about severity of symptoms. And the test is positive today. But we know that, again, the exposure was probably last week. Again, that's why in medicine, we always do history. You ask all these questions of what do you think happened? Where do you think you were exposed? So now, counting from Friday, positive today, Tuesday, then we'll keep saying, okay, from today that you're officially positive and you got tested, keep monitoring for symptoms. Hopefully your fever breaks within 5 to 7 days, but clearly by day 10, which will be next week, Friday, you haven't had a fever. From next week, Tuesday, you're feeling better. By next week, Friday, you're actually officially released and considered non-contagious at that point. Because most of the contagiousness is actually within the first 2 days of being exposed, 2 to 3 days. So again, using my example of you were in a function on Friday last week, you're feeling crummy, you got tested today, Tuesday, you have actually been contagious also to other people from probably day before yesterday. So that's why you got to notify your close contacts and say, I just got tested today, Tuesday. I think it's just something that happened on Friday. Now, I was hanging out with you on Sunday. I didn't know I had COVID or I was developing COVID symptoms. So those people you were exposed to 2 days ago should kind of monitor themselves. Do they have to get tested? Probably not, but they can monitor for symptoms. For peace of mind, they can get tested. The first test for them may be negative because they haven't built up the material that's going to be positive in their nostrils. By Thursday of this week, they may get tested again, and then they may be negative or positive. So essentially, your contagiousness is up to 2 days before showing symptoms and for the first 3 days of your symptoms. By the time your fever is breaking, by day 5, day 6, day 7, you're less contagious. And by next week, Friday, day 10, you're considered not contagious or able to transmit the active infection at that point. And that's why you're cleared to go back to work and do anything you want to do. Your nostrils will still be positive, but you're not contagious. So again, I know it's a bit confusing. There's a lot of information I've just shared, but by day 10, after a positive test, you don't have any more symptoms, your fever is broken, you can hang around anybody, they can hang around you safely, you're not contagious or dangerous to them.
Thanks.
Thank you.
Yeah, and there's new guidance as well for contact tracing and monitoring for unvaccinated versus vaccinated individuals. So there is a difference now. If you have a high risk exposure and you're not vaccinated, you would need to isolate and things like that. And of course, test. And for vaccinated individuals without symptoms, they're able to test. And if it's negative, they don't need to isolate. So there are benefits of vaccination in just daily life, being able to not be isolating if that test is negative and there's no symptoms. So the rules are changing, and public health will always reach out to you to provide guidance if you're getting tested or you've had an exposure. Two more questions came into the chat. One is, can an individual with sickle cell get the vaccine?
I haven't read or heard specifically that they can't. And in fact, I will argue that sickle cell being a condition that when the cells sickle up and reduce the oxygen carrying capacity of the red blood cells, which leads to hypoxia, definitely a sickle cell patient should be protected. But I'll leave the 1% room that you should probably ask your hematologist or the sickle cell specialist. But again, I haven't heard any specific exclusionary criteria of sickle cell. We know that right now the Association Academy of College of Obstetricians and Gynecologists is really pushing for it to be given to pregnant women because, again, pregnancy leads to hypoxia, the delivery process leads to potential for embolism and other complications of the natural process. And again, being COVID protected will be one less thing to worry about. So most people with chronic diseases and chronic illnesses, 99.9% of those chronic illnesses are actually reasons to be vaccinated, rather than being a reason not to be vaccinated.
Yeah, great, thank you. Yeah, we get a lot of questions in public health like that, and we always say, if you do have a family physician, then that's the person who knows you best, that they can help answer those questions as well. Another question came in. So could you just quickly review the side effects again of the vaccine, and how long would someone have pain after vaccination?
So the commonest side effects will be tiredness, fatigue, mild fever, very low grade chills, and achiness at the injection sites or muscle aches and pains diffusely, typically 24 to 48 hours. And I've not heard any of my patients call me and say they were still achy 3 days later. And so it's pretty much self-limited within a few days. Taking Tylenol, nothing wrong with that. Taking a non-steroidal agent like Advil and Aleve, ibuprofen, Motrin is also great. There was some reports anecdotally early in the COVID process that taking Motrin or non-steroidals could be harmful, but there's no negative effect that's been shown from taking NSAIDs. Again, more serious side effects, but not fatal, thankfully. It could be young people that develop a bit of chest pain due to inflammation of the heart lining called pericarditis, or the heart muscle itself, myocarditis. It's not a heart attack. It's not a stroke. It's not a fatal irregularity that will lead to the heart stopping in any way. And usually with rest, lots of fluids, and taking ibuprofen or Advil or Aleve under the doctor's guidance and monitoring, that side effect also will be mitigated within a few days. Pain, everybody's pain tolerance is different. Some people don't like needles on any good day, whether it's a COVID vaccine or any vaccination or getting blood drawn for testing. So the pain of a COVID vaccine in and of itself is not any more unusual than somebody getting a jab and your body knowing you got a needle. I don't feel pain for shots, but by 8 hours later, kind of feel a bit sore, and within 16 to 24 hours, it's all gone. So it's not a vaccination that has a particular chemical that makes it burn or is more painful than usual for a prolonged period. That I can reassure you about.
Great, thanks for clarifying those again. I don't see any more questions in the chat. Are there any final questions from any audience members?
There are a couple that were direct message to me, so I'll run through.
Okay, perfect.
Somebody wrote can the COVID vaccinations affect any other drugs from working in the immune system? Again, not that I'm aware of. COVID vaccines do not interfere with diabetic drugs or blood pressure medications or cancer chemotherapy or any other things that's administered to the patient or anybody. Another, the same person. Also, during the COVID test, why do they put the swabs so deep down the nose? Can't there be another convenient method? We know that because COVID-19 is primarily a respiratory illness, it's inhalation through the nostrils and trachea and the lungs, and that's why most of the effects are initially respiratory. So there's a lot of viral replication in the bronchopulmonary tree, and because this is accessible in the nose, it's why it's done that way. It could hypothetically be done by putting it down the back of the throat, but that will cause gagging and choking also. The tips of the nostrils don't have a lot of the viral particles. The more moist, deeper part of the nasal passages is where the viral particles are replicating more. So like any test, if you do it, it's got to be done well. So you can truly be reassured that if they say it's negative, it's a true negative. But if you just tickle the outside of the nostrils and they say it's negative, we haven't really collected enough of the samples of the virus that we're trying to see whether it's there. I have it done twice a week. I've been getting it done twice a week since May of last year. I work in 2 nursing homes. I'm an expert. I just take a deep breath in and I let the poor people that are doing it in the nursing home do their jobs. They don't like doing it. It's not anything that anybody takes pleasure in doing, but we all have to be subject to these things for the common good. So, and again, I'm not promising you that this is going to happen in your environment, but I've also seen environments where they actually do self-administered. They'll watch you do it, but they'll say, okay, you don't like the pressure I exert. So you stick it in there 1 inch, roll it around for 5 seconds. In your mind, count 1 to 5 in the first nostril, put it in the other nostril and count 1 to 5. And again, it's based on trust. They're watching you and I hope you put it in 1 inch. I can't promise they'll let you do it self-administered, but I've seen them do it a few times in some facilities. There is a saliva test that's coming out. It's not approved yet for everyday testing. Again, talking about saliva, some people will like this thought of it. You don't have anything up your nostrils. Some people will be like, that's kind of yucky, being told to spit into a bottle. But if the saliva test is approved and for common everyday use, maybe that's an alternative to for somebody who doesn't like the nasal swab. Those are the 2 direct questions.
All right. Any other audience questions before we wrap up the session today?
Sharon had a question direct to me also. If COVID becomes non-contagious after 10 days, why do we have to quarantine for 14 days? It's a great question, sounds contradictory. The only thing is if the person is quarantining because they were exposed, they may not be contagious for up to 5 days. They may not manifest the illness for up to 5 days, potentially even 7 to 10 days. So the person who is quarantining is kind of nervous because you don't know whether you're going to fall sick or not. But we know you don't fall sick on day 1 after an exposure. It could be up to 5 to 7 days after the exposure. And in fact, some data shows that it could be up to 14 days. That's on the outside limits. I know that some countries are now talking about quarantine for 7 days, even 10 days. But I think in Canada in particular, we're being very, very cautious and we're realizing that there are 1 in a million people that will still be contagious up to 14 days. But again, on a personal level, I've had to quarantine only once, very early in the process in March of last year, before we knew what it was all about. I was in a conference, got a call from Peel Public Health in Mississauga that somebody in that conference of 18 doctors has COVID. They didn't tell me the name for privacy. And I was told to stay home for 14 days. And I was a basket case for the first 7 days. I was checking myself and wondering if I was feeling short of breath. But by day 7, I knew I was pretty much out of the woods, but I respected the rules and I stayed away from people for a full 14 days just for safety.
And that's recently been updated as well for Ontario. So it is actually 10 days now. So
Okay.
it's 10 days for both like having COVID and for unvaccinated individuals who are high risk close contacts. And I believe the rationale for changing it from 14 to 10 was because with Delta, symptoms were showing up faster in like the first few days, as opposed to before. Some people were getting sick on day 10. But still, I mean, if you have an exposure and you start feeling sick after day 10, you still need to get tested. So really, if you feel sick, get tested. That's the safest thing to do right now.
That's great. Thanks for clarifying, Sharon. Even I learn on a daily basis, that's how much this is evolving.
It changes so frequently, especially all the case and contact management stuff like that. So yeah, 10 days right now. And we just encourage everyone to get a COVID test. And they reopened the Main West Test Center. The urgent care, there's testing there again. It had closed down, but now it's open for testing again, as well as the St. Joe's West 5th near Mohawk College. So there's 2 of the testing sites right now for people that need a COVID test.
Great.
Yeah. All right. Any other final questions? Okay.
Okay, it looks like that's all for now. I'd just like to say thank you to you, Sharon and Dr. Ayeni, for taking the time to meet with us. It was wonderful. I think we've got a lot of questions answered and we have some clarity on some COVID regulations. So thank you very much. And Sharon, hopefully if we have any further questions, I can just email them to you.
Yeah, and if anyone wants to email questions directly, you can email vaccineconfidence@hamilton.ca. And I also check that inbox every day. And if I do not have the answer, I will forward it on to a colleague who's able to answer that for you. So again, vaccineconfidence@hamilton.ca. And if you're looking for a site to get your vaccine, you can go to hamilton.ca/get-your-vaccine, and it lists all the clinics, and they're updated like throughout the week as new clinics are added. All right.
Okay, great. Thank
Good.
you.
Thank you for having
Bye.
us. Have a
Thank
great
you.
day.
You too.